Okay, our next speaker is Dr. Daniel Friedman. He's an assistant professor of medicine here in psychiatry, and he will be speaking on the team approach as it relates to psychiatric conditions before transplantation. Dr. Friedman?
Okay, thanks so much. So I'm Dr. Dan Friedman. I was trained in both internal medicine and psychiatry, so I did a med-psych residency. And just I'm going to talk a little bit about the team approach and having a psychiatrist as part of the transplant team and what the benefits that you can get from that. So hopefully I'm your friendly neighborhood psychiatrist and not a threatening one. Mental health professionals as well as psychiatrists can typically help in evaluating and treating all your transplant patients. Some programs require every single patient to be evaluated by psychiatry. Some really just pick out specific patients that they feel they have that they might have issues with in terms of whether they can partner with the team or follow directions or might have problems afterwards. It's important to do this not only for the transplant recipients, but also living donors as well in some cases. When I was at UVA, I had a case where there was an 18-year-old girl who wanted to give her kidney to her minister that she had just met. And in the end, I didn't allow it. But you can get into all kinds of kind of interesting situations where sometimes it's appropriate and sometimes it's not appropriate. And why is a psychiatric liaison important? There's obviously a lot of organs that are needed, and unfortunately we don't have as many organs as we can give to patients. And so in a lot of ways, the need greatly exceeds the supply. And each year, many candidates do die on the wait list. And basically, in order to optimize the outcomes, we try to have the appropriate patient chosen. But, in addition to that, we do want to be egalitarian. We do want to make sure that everyone has the option of being able to get a kidney if that's, possible. Having a liaison has a better preoperative management, better surgical innovations are available right now. We have less toxic immunosuppressant medications that reduce morbidity and mortality, but there's lots of behavioral factors that can really come into play when you have somebody who has to follow difficult treatment regimens and come to appointments and take all their medications, et cetera. In addition, there's kind of a lifelong change that people have to make that they don't necessarily make. A lot of times, especially for end-stage renal disease, a lot of times it's pretty silent. So people don't really know that they're developing significant renal disease, and so they don't think it's real. And they don't understand that they need to make a significant change. A lot of times when I'm evaluating people, I'll really make a point about finding out what their dietary, how they're following the dietary guidelines, what they understand about the diet, and how they're really living their lives day to day, and that'll give me an idea about what's going on with them. Typically, we assist in evaluating and preparing the patient and the living donor and addressing kind of the psychiatric issues beforehand, as well as anticipating what will happen during transplant as well as after. For mood and psychotic disorders, you have a careful selection of patients that will really kind of benefit overall the people that are coming in as well as the whole outcomes. And as I said before, equity is pretty important for disadvantaged patients. Each transplant program decides what their psychosocial criteria are and the relevance of these criteria, but the input from mental health is important. Typically, you'll have a psychologist that's affiliated with any kind of transplant team that's embedded, and in our case, I think we have social workers that do much of the psychological work that will screen people, but then we do need to have somebody to kind of look through. So just doing a GAD-7 or PHQ-9 or something like that is not going to be enough. Nothing really replaces kind of a face-to-face interaction. There's always been concerns about whether somebody with serious mental illness or at least severe mental illness such as schizophrenia or other kind of psychotic disorders that would be like major depression with psychotic features or something like that, PTSD, MDD, or major depression and bipolar disorder, whether we can transplant these people or not, and whether they make appropriate candidates. I think my feeling and many health professionals' feeling is that we can treat these people, and they are entitled to have transplants as long as they're carefully evaluated to make sure that they can, follow guidelines. Some guidelines consider a pre-existing psychotic disorder as a contraindication to transplant, even though there's been plenty of studies showing that there have been positive outcomes. So these are the critical issues that typically happen in these cases for the liaison. We help with patient selection and informed consent so that patients can understand what they are signing up for. Recognition and pre-transplant treatments of psychiatric disorders. So sometimes we'll get a patient that is evaluated and requires a year's worth of treatment to get them to the point where they are actually capable of following whatever procedural things that they will need to do in order to get their transplant, so they get to the point where they're capable of having the transplant. We evaluate for substance use disorders. I would say that certainly for renal transplant, you need to do that. Obviously, for other transplants, it's even more important. Compliance with medical regimen. If I have a patient who can't tell me the names of their medications or the dosages or what they're for, that makes me feel a little bit suspicious compared to somebody who can rattle off all their medications and know what they're taking those medications for. Post-transplant psychosis is another one that's pretty important in terms of evaluating the possibility that will happen, or once it does happen, what to do for that, and as well as what medications to avoid. And then evaluating kind of the immunosuppressive drugs and the drug-drug interactions that were caused by that and the problems that come from that. Knowing what a transplantation patient's adaptive strengths and deficiencies are beforehand is really important, and it strengthens overall the working relationship between us, their family, the patient, other caregivers, and it improves the support that the patient will get. Also, patients who are waiting a long time, I'll have patients who I think I have one that I've been seeing for almost 3 years now that looks like they're finally listed, and hopefully they'll be able to get a kidney at some point in the near future. But sometimes the wait list is very long, and we're also there to help a patient adapt to the fact that they haven't been able to get a kidney yet, or there is a long wait. Early diagnosis and management of other psychiatric conditions is really essential overall. Choosing a candidate should be overall egalitarian, but otherwise, criteria for listing patients vary in response to total mental health considerations. Selections varies. It used to be that people didn't want to transplant somebody who's on a methadone, in a methadone program, but in truth, if you're in a methadone program or you already have identified the fact that somebody has a substance use issue, that's a known quantity, whereas if you have no idea whether they have a substance use issue, they're using substances and yet they're doing it secretly, that's something that you don't know about and you don't have an idea and you can't help with. So truthfully, knowing there's an issue really actually helps out and helps you to be able to manage that patient more effectively. There's been several studies showing that people on chronic maintenance methadone therapy and treatment actually have a favorable outcome. But typically we can restrict and not be so equal in terms of the patients that we decide to have to allow for transplant in regards to their advanced age. We might be ageist, people with memory deficit problems, people with a history of alcohol or substance use, as well as people's size. Sometimes people will not let people be transplanted because they're too large. But we can adapt and we can adjust for many patients. Patients suffering from psychotic disorders were also, as I said before, prejudiced against. But there have been plenty of studies showing that those with psychotic disorders actually have a favorable outcome. But it requires a lot of support from their family, a lot of support from the treatment providers and the mental health team. So the psychiatrist as a team member helps to choose who's a good candidate. At times, the evaluation that the psychiatrist does can be many, many months later than when the initial evaluation from the team happens. So, for example, we just had a patient who she had an elevated GAD-7, the General Anxiety Disorder 7, test as well as the PHQ-9. They were both elevated, and she was feeling, they felt this needs to be seen by me to make sure that she's okay. And when I saw her, she was fine. Her GAD was, I think, 3. Her PHQ-9 was like 2. And when we were discussing it in team, we were talking about why were the numbers so different? Why were they so different when she was evaluated? And the reason was because she was just diagnosed at that time. So she didn't know what was going on. She didn't know what the plan was for the future. She didn't know if she could get a kidney or not, or what would happen. She hadn't even started hemodialysis yet. And so she's like thinking, oh my God, I don't know what's going to happen to me. And meanwhile, by the time I saw her, many of those questions had already been answered, and she felt much better. She felt much more confident about what would happen. And thereby, we didn't really have to treat her for any pre-existing conditions or possible conditions like that. And we just made it so that I would follow up with her when she needed to. She actually agreed to have kind of a follow-up in several months. Those are the kinds of things that we can add to a situation. For any transplant recipient, it's important to figure out whether a patient can adhere to a complex regimen. Most patients are able to manage their own medical care eventually after transplant, but there's really no way for somebody to be able to follow all their treatment advice right when they've had their transplant. They're quite ill, they need a lot of extra support, and so sometimes we get patients who really can't identify any social support at all that they're going to have. They can't identify a family member that will be consistent, or community members that will be helpful, and those present difficulties because you really do need a lot of social support. There's just so much that we can provide for patients, and they really do need to have somebody else kind of helping them. The incidence of noncompliance varies from study to study, but it basically, noncompliance accounts for about a 7-fold increase in renal transplant failure. So it's very important to figure out medical compliance. We've certainly had patients who've only taken, 1 month's worth of their medicine after their transplant because they just said, oh, they only gave me a bottle with 30 pills in it, so I don't need any more. But obviously they did, and so hopefully we help to kind of weed those kinds of patients out, or at least educate them to the point where they actually take their medications. Common factors leading to noncompliance can include depression, substance use that's active, memory impairment, adolescence, and social or financial instability, all kind of for pretty obvious reasons. Patient attitudes towards efficacy and how they can make a large impact, how the care can make a large impact is pretty important. When medical problems, like I said before, are asymptomatic, it's really hard for patients to say, oh, I'm sick and I need to follow these instructions, so they tend to ignore those instructions. When people are depressed, they tend to have a negative view or a negative view of the outcome or the future, and that will lead them to not follow certain things or have a negative way of responding to their problem at the time. Obviously, substance use is going to, that speaks for itself in terms of people's inability to follow up if they have their lost weekend or something like that. But dietary problems among people with diabetes, as well as people who are overweight or obese, people with smoking habits or physical inactivity, all will affect the outcome. And even those kinds of social support in terms of lifestyle is very important and needs to be repeatedly addressed for many of our patients. A transplant recipient's expectations and attitudes have a marked effect. So if people think, oh, well, my brother-in-law had this, so I know it'll be fine. He had a pretty easy time. It's problematic when they've gotten some either disinformation, misinformation, or problems with understanding exactly what the procedure is. Like, they're not going to get a kidney and it's magic and they don't have to do anything. They have a lifelong change in their lifestyle, and they have to be adjusted to that. Depression and anxiety leads to a lot of negative self-perceptions. They can cause them to make poorer choices. Patients who have these negative thinking can really be hooked up with a psychologist or a LCSW who does good CBT therapy, and CBT therapy has been quite effective in helping people dealing with a lot of their conditioned negative thinking. The team together tends to make a kind of a realistic approach to who's going to have a good outcome for patients. But teaching patients at their educational level is very important. A lot of patients will not understand some things that are quite complex, so keeping it very easy, making sure you're using a language that is appropriate for the patient. I've certainly had patients who insist on talking in English, and they say that they know English and they'd rather be addressed in English, and yet I will find in my interactions that there is many times when they seem to misunderstand a key component of what we're talking about, and although it seems like they're understanding, they actually aren't. And although you don't want to upset somebody, there has to be a way that we can address the patient and say, I think it might be advantageous for at least some of our sessions to be in your language of origin. Because it's going to be helpful, and when it gets right down to it, if it's between a failure of their transplant or offending them because you want to speak in a different language, I would choose the latter. Expectations can be harmful. A lot of times professionals who are not as familiar with transplants, so medical doctors that don't know as much about transplantation, or people getting information from Reddit or something, I usually restrict my patients. They can only go to websites that say .gov or .edu. They can't go to any other websites. But people get a lot of misinformation, and they have a lot of reasons why they think that that either they're a shoo-in for a transplant, it'll be easy, or that it'll be too hard and they better not get it. And so it's also up to us to educate people and to let them know, what hopefully they can be capable of. So for depression, it can have a significant impact on a patient's cognition. It can include their ability to concentrate, their memory, their behavior, their affect. And the thing is that, people who have had a history of depression in the past, they are certainly likely or possible to have another reactive depression or another depressive episode, depending on what's going on in their lives, especially with the medications that we do need to use and some of the treatments that we have, or the condition that they're in, or the pain that they might have, all can lead people to another episode. So being prepared for that, being prepared for the changes in cognition and vegetative functioning are all important. Overall, depression increases the risk of mortality as well as disability from major diseases, including end-stage renal disease. Factors increasing morbidity-related depression include excessive weight gain or loss, altered immune function, and overall, there's the theories in the same way for many other disease states. For depression, it's an elevated, cytokine response. There's increased interleukin-6, increased interleukin-2, increased interferon gamma. There's many cytokines that are elevated, and the reasons why people are more depressed with diabetes or more depressed with hepatitis C or more depressed with many other disease states is because it mimics the same thing that happens in depression. So all of those things are happening. So that can certainly make an impact. Loss of activity, not exercising, and changes in the way they process information all have a significant impact that will impact the team, really, and the transplant plan. Depressed people typically have decreased perception of their own self-worth, as well as feelings of lethargy, fatigue, and it will make rehabilitation much more difficult if it's not treated. So people who are on the precipice, I try to get them to, sometimes people will prophylactically go on medications if I feel like that's important, if I feel that that's close for them. There's many people who have had a history and they feel fine, they look fine, they've got a lot of support, and they don't need to prophylactically go on something. But other patients, if I feel like, increased stress for this patient may lead in this direction, I may actually pre-treat them in the hope that I could avoid a depressive episode if we're already treating. For depression, medical morbidity exacerbates depressive symptoms. So the more pain you have, the more problems you have, the more depression you have. The more depression you have, that then will lead to higher feelings of pain, et cetera, and it's just very cyclic. With treatment, usually you can kind of break the cycle. Depression doesn't include people from transplantation like many of the other conditions also don't, but it emphasizes the importance of having that diagnosed. Treatment of depression pharmacologically and psychologically is important, so you could certainly start someone on SSRI is a very good outcome, and it's quite easy usually to do those. You need to make sure that people understand the psychopharmacology. I know we just had a patient last week where we were thinking about starting duloxetine, and duloxetine can be quite toxic if your creatinine clearance is less than 30, which it turned out to be, so we couldn't use it. So it's mostly renally excreted, so we couldn't use that medication, even though we were hoping to use something that would help modulate pain for the patient. And the spinal thalamic tract is modulated by serotonin and norepinephrine, so a lot of SNRIs are helpful for pain, like duloxetine, but we couldn't use it in this case. CMV infection is also, and rejection are kind of a leading cause and something that can be quite difficult, causing an acute onset of post-transplant depression. Bipolar disorder, a more serious mental illness, does not preclude somebody from getting a transplant. Mood stabilizers, though, can be somewhat tricky to work with. Lithium, of course, is quite a difficult medication to have a patient on who's on who has end-stage renal disease, and yet we have patients I've had floridly manic patients that will only respond to lithium in teeny tiny doses. I can give them anything else and they're quite psychotic and manic, and then I give them a tiny dose of lithium, and within 2 or 3 days they're under much better control. Those are quite, those patients are very difficult. They might not be able to get a kidney because of those reasons. But mood stabilizers in general can be toxic. The anticonvulsants have a potential effect to interact with the immunosuppressive medications. Some anticonvulsants most of them will affect blood lines, so certainly carbamazepine and divalproex will. Second generation antipsychotics cause metabolic side effects and diabetes, and also require you to be a little bit more careful, although in terms of treatment, you can use those medications quite easily in a patient who has renal insufficiency. At times, smaller doses of medications, or sometimes small doses and multiple medications, but I'll keep them all small, sometimes works quite well for people. Post-op bipolar exacerbations can occur. Typically, prednisone is the thing that's the most problematic, causing mania and psychosis. Identifying those patients and making sure you use a prednisone-sparing regimen would be quite important. For psychotic disorders, as long as there's been a psychotic disorder and it's well maintained with a lot of community support, a lot of social support, family members, they can be successfully transplanted. And there's been studies showing that people have had successful transplants even though they've had a serious mental illness like schizophrenia or schizoaffective disorder. For substance use disorder, prognosis is favorable with good patient selection, so you have to select the patient appropriately. And patients, so they need to freely acknowledge their diagnosis and agree to sobriety. Patients may need to see an addictionologist, a specialist. Naltrexone and other medications can be used. Patients with a narcotic addiction can successfully be transplanted on methadone with a methadone maintenance patient. It's just that their pain management is going to be a lot more difficult to manage because of their history, but that's not something that the pain service or someone can't manage for the team. Besides the many medical complications patients experience, you need to manage the medication side effects, episodes of rejection, episodes of infection, and the continued burden that people will have because of economic stress, because they can't work. A lot of times, even though patient support networks will say, oh, we'll be there every day, we'll be there to do anything, many times we'll see patients' family members or support systems, evaporate after the transplant, unfortunately. So again, looking out and seeing the family, I have to say, I don't think we do that as much as we probably should. Maybe have a meeting with the family members, or I don't. Finding out, how supportive they truly are. For new onset psychosis that can happen post-operatively, it can occur likely as a result from the stress. Related exacerbation of a psychotic disorder can be due either to abrupt discontinuation of medications that happens because of surgery, or because of drug-drug interactions, or from a medical complication. Deliriums can occur due to intraoperative complications, toxicity from medications like CNIs. We did think we had a patient who had a catatonia directly related to tacrolimus, and Yeah, and so we did. So I'm getting positive things that we did. So okay, we did. And so having an understanding of what some of these medications can do and their side effects and psychiatric complications from them. And believe me, every medication, every antihypertensive has a psychiatric side effect. Even hydrochlorothiazide has been known to cause psychosis. So, I mean, you'd be surprised at the side effects from medications, from ACE inhibitors. So, I mean, again, we're using complicated medications post-op transplant, and there's many, many side effects and many drug interactions that a psychiatrist, typically because we do a lot of more pharmacological training, we have an expertise in. So there's other problems can be infections that cause deliriums, drug or alcohol withdrawal, metabolic changes, vitamin deficiencies, and endocrinopathies and hematological problems. Also, just discuss quickly that CNIs have neurological side effects: tremor, headache, restlessness, insomnia, vivid dreams, photophobia. In severe cases, there can be cognitive impairment, coma, seizures, etc. Factors associated with neurotoxicity are believed to include hypercholesterolemia, hypermag, and genetic polymorphism. And we talked to you about the CNI-induced catatonia, which we did switch them to a different agent with some success, I would say. Yeah, exactly, and a lot of Ativan. But anticonvulsants, like we said about like valproic acid, carbamazepine, oxcarbazepine, they have P450 inducing properties that may decrease the bioavailability of the CNI, so you have to take that into account. And then I just wanted to end with an example of a patient, which we were just discussing last week. We have a native Spanish speaker, really unable to speak English. He's a 54-year-old man, first seen in 2022, past medical history of diabetes and hypertension, and in the Dominican Republic had recurrent renal calculi of an unknown type, and caused, in the end, end-stage renal disease and hemodialysis, GERD, diabetic retinopathy, cataracts, etc. No psychiatric history before any of this. And when I was asked to see him, I think he had been placed on a very small dose of fluoxetine, 10 milligrams, by his primary care doctor because he seemed depressed, but that was really the only interaction that he'd gotten. Just so you know, 80% of all psychiatric medications are prescribed by non-psychiatrists. Only 20% of psychiatric medications of any type are prescribed by a psychiatrist. So the patient was when I met him, he was very, very upset because he didn't get the appropriate treatment when he was in the Dominican Republic. And for him, his renal calculi came from something he could have avoided in his diet. And if he was just told, he would have not developed, repeated renal calculi ending in renal failure. And so he was really upset that he had to start dialysis, really upset that this could have been prevented. And when he came to the U.S., and he got appropriate treatment, he did well, but he was still quite angry, very angry, as well as depressed. He told me that he was depressed since 2017. He had to stop working then. He had, more sadness, anxiety, kind of anhedonia, poor sleep, crying spells, lost about 20 pounds. And since then, he'd had kind of chronic passive suicidal ideation, so nothing active, but repeated thoughts. He tended to isolate, wasn't doing a lot, wasn't as active as he'd been, and like I said, he'd been on 10 of fluoxetine, and his PCP gave him mirtazapine at 50. For mirtazapine, the lower the dose is actually the more somniferous it is, so 7.5 is actually more sleepy-making than 15, and he felt the meds weren't working. I don't love fluoxetine as a medicine because the half-life is super long, and then norfluoxetine, which is a metabolite, that has a week-long half-life. So sometimes it's difficult to work with that medicine because it takes 2 months or 3 months to really figure out what one dose did to, accurately. So I usually prefer shorter-acting SSRIs, but he was already on it, so it's easier to just adjust something that he's already on. I went ahead, I went ahead and I continued asking him questions about his depression, but also because I'm a psychiatrist, I asked him, questions about mania, OCD, all kinds of things. And when I asked about hallucinations, he said, "Oh yeah, I have had voices, when I got really down." And this was the first time anyone had heard that he'd ever had any auditory hallucinations. And he had voices that told them that he said that they were pushing him. The voices told him to harm himself. He stated that when I had seen him, he had last heard a voice about 2 weeks before that, but they weren't familiar, but they were repeated, the same voice all the time. And he noted that when he felt more depressed, he heard more voices. So it seemed more like a major depression with psychotic features. He was not really afraid of the voices, kind of ignored them, but was significantly bothered by them. He had a lot of faith in God. He felt that was protective, and he could ignore the voices. And even though the voices at times told him to throw himself in front of a car or something like that, he would ignore them. And he agreed at the time to take more medications in the hopes that we could decrease his auditory hallucinations. We went ahead and started him on Risperdal 1 milligram QHS. I might have started at half a milligram, but we went up to 1 milligram. We also increased his fluoxetine from 10 to 20, and after that, he did so much better. So he had had a problem with being sad, crying spells, etc., and now he's not having any crying spells. He's sleeping better. He had had a difficulty with flipping his sleep-wake cycle and sleeping during the day, which we fixed with a little bit of quetiapine. But overall, he's remained on these. He hasn't had voices in, I would say, probably about a year and a half. Much, much happier. And I just think about the amount of time this poor person suffered, from these auditory hallucinations that no one just had the wherewithal to ask about because, they feel uncomfortable asking about voices, or they're not sure that they know how to ask them in the right way. But in this case, it was pretty important. At the time, he felt very worthless. I feel I'm worth nothing, is what he said. And with treatment, he got remarkably better, and I know that he was just listed. Thanks. Any questions?
I have a question.
You in the background. I may not be able to answer it, but you could ask it.
So I liked how you touched upon a lot about depression, which I think is underdiagnosed in our population here. However, there's a lot of stigma, I think, in our population regarding talks about mental health and seeing a mental health professional. What are ways in which you think there's workarounds around that? What would you tell patients, or how to help patients in taking that step?
Yeah, that's interesting. Obviously you can strong-arm things in one way because you could say, without getting this psychiatric consult, you're not going to get an organ. And so you could kind of make it happen, which I think I see sometimes. But including them, including their family members, in all these kind of conversations, sometimes actually having a patient separate from their family and talking to them just regular. I'm a big believer in having conversations, very plainly, without a lot of jargon, a lot of, medical talk, can be pretty helpful. I often will talk to people about that they don't have to be on medications forever, that just because they're going on a medication to treat something that's going on now does not mean it's permanent or for the rest of their life, and that I'm available for them even when they're off the medication. So we would try medications for a certain amount of time and then see how they do off those medications, but I'll be available to see whether I can help or whether there's problems to maybe have to restart. But I know that there's a lot of stigma, and I think they know that there's a lot of stigma as well. So it's not something that's unheard of for them. They have TVs, they watch movies, they see what happens in the general public. But yes, there are certain communities where there really is a big stigma. But I think addressing it straightforward and being very honest, and also expressing your own concern so that they can see, my provider has feelings and they have emotions and they are concerned about me. I think that will go a long way, and people pick up on that.
Yeah, thank you for that. Working around those stigmas is certainly a big challenge in our pre-transplant workup. I have another question for you. As you mentioned, transplant psychiatry is becoming a transplant specialty. There's some programs who have everybody seen by psychiatry, and that's because the incidence of mental health issues and psychiatric disorders and organ damage is very high. Now, in liver transplant, it's almost something that we accept, right? Because there's a big part of how people have damaged their liver that was related to psychiatric illnesses.
Mostly.
But in kidney disease, it's harder to explain. So why do you think the incidence of psychiatric needs is so high in the end organ damaged patients? And how can we better support the population to increase their access to care? Because I believe that some of the psychiatric illness also leads to decreased access to care.
Yeah, I mean, I have to say, I just think more education for them, having them see more mental health professionals that don't have to only be psychiatrists. There could be psychologists, there could be LCSWs, all who have good training. And, you know, I'm a big believer in groups. And so having more groups, having more, you know, even if they're drop-in groups, you know, so that people don't feel like they have to go every single time. But, you know, maybe making it in a convenient place, maybe making it near where they come for their follow-ups anyway. But having groups of people in similar situations who can all hear kind of the same information, I think that can only be helpful because they not only see what's going on with them, they hear stories from other people as well that they can self-identify with, and thereby maybe kind of scooting around an issue and being able to help people out. So having those options, you know, getting people to do it, that would be just taking encouragement. I mean, you know, I've worked with patients in my primary care practice when I had that. You know, I would say you really need to quit smoking, and I would say it for, you know, I'm going to say it for 2 minutes every visit, and then 5 years later they quit smoking or they quit drinking. So I mean, you know, you will have an impact as long as you are, you know, consistent with how you address things and the way you address it. If you come across, you know, cross or mean, they're not going to respond to it. But if you come across in a caring way and say, I know it upsets you when I bring up this issue, but, you know, as your care provider, I feel it's really important to do it, so please allow me to do so. And then, you know, as long as you telegraph all your moves, no one's going to be angry. Okie doke. Thanks.